Thank you so much. It was an honor to be here with us again. The talk is about the pancreas as you have never seen it before.
Oh, thank you very much. I'm very happy to be here with you. I have to apologize, Laurence, if you don't mind. I thought we were Wednesday, so it's just... So who cares about pancreas anyway? Okay. So, well, I would like to show you this case of young adults. This is a 23-year-old female with shortness of breath and chest pain. And, well, this is the X-rays. You can guess, first of all, that it is a lady, and second, that there is a differential, and the differential would be A, lymphoma, B, lymphoma, C, lymphoma, and D, maybe lymphoma. What would you choose? Okay. And therefore we went for a staging, and staging showed the CT, which was a little bit unusual for a lymphoma, showing a very heterogeneous mass, so we cautiously went to surgery. And as you can imagine, this was pancreatic gland, and this was pancreatic fluid. So this is quite unusual, and this is why I decided to present this case and as an introduction to this talk, the pancreas as you have never seen it, probably. I guess you haven't seen so many a chest case of a pancreatic masses. We need to be helped by some animals. I would like to pay a tribute to some nude mice and to this fish, which is very interesting for the embryology because it's transparent when it's a baby. So we can look at the pancreas just without killing the babies, which is very good. And this is how we learned. And we learned one thing with embryology, which is that we have, the human as well as the animals, we have a combination of two buds originating both from the primitive intestine. And this is very important. One is dorsal, we sometimes refer to it as a posterior caudal, and another one is ventral, and we'll sometimes refer to it as anterior cranial. And what we need to understand is that in the embryo, which is behind, is completely different from what is in front of the primitive intestine. And this will be important for understanding of the pancreatic diseases. The dorsal bud behind, the development of this bud is heavily influenced by two organs, which is the notochord, which has something to do with the neuro, and the primitive aorta, which is the vessels. The dorsal bud is the child of neuro and vessels. And the development is under complete control. So the vessel and the notochord are saying to the pancreas, grow, grow, just like you are driving back. Somebody is telling you, yeah, go on, that's it. It's doing it all the time. And when the pancreas is big enough, the aorta and the notochord will say, that's it, stop it now, you're big enough. And in front of the primitive intestine, this is completely irrelevant, because the ventral bud, which is here, is in front of what we call the anterior primitive mesoderm. And I have to confess that there was something I completely ignored. The primitive mesoderm is telling to the intestine, please develop. But it's just saying that, develop. And after that, it doesn't control anything. And did you know that the heart is the father of the liver? This is the early anterior mesoderm. This is the primitive intestine. This is the place where the heart is developing. The primitive heart is secreting something which tells to the intestine, this pink area will become something, this green area will become something. And there is some kind of biochemical dependence. And finally, which is pink will become the liver, and which is green will become the bile duct and the ventral bud of the pancreas. So the heart says, I need a liver, I need bile ducts, and I need a pancreas. And you can understand on the adult that the liver and the heart are really all together, and the hepatic veins are something like a combination of heart and liver vessels. And this is interesting to understand. But well, now we have two buds, one in the front, another one behind, and we have to reorganize it because the embryo is going to be a baby and an adult, and we need to rearrange everything in the body. So there will be something that we call the duodeno-pancreatic rotation. Both buds will have a different history. The dorsal bud will turn around 90 degrees just relatively passively, because this passive rotation of the duodenum is related to the growth of the stomach. The stomach is getting bigger, so it has to go on the left side, and because it has to go on the left side, everything will turn around 90 degrees. And the dorsal bud will just follow this movement. Why the ventral bud is going to do not 90 degrees, but 270 degrees around. And why does it do that? It's very active. It does it because the liver is getting so big that it pushes. Not only the duodenum is rotating 90 degrees, but also the liver is developing and pushing behind 270 degrees. And at the end of it, the two buds join together to form the final pancreas. This is not the case in all animals. This is the case in humans. In humans, we have finally one pancreas. Some animals keep on with two pancreases. So this is how the liver does. This is the stomach. The stomach is getting bigger. The liver is getting bigger. And the liver is pushing behind the duodenum the growth of the dorsal bud and joining together with the ventral bud at the end stage. So the ventral and the dorsal buds are completely different, and there are some consequences. They have different origin and determinism, and this is how we see it in the adult. Look at this fatty differential, this fatty deposit in the pancreas. This is the ventral bud, this is the dorsal bud. This is exactly the difference between the two buds. One is fatty, the other one is not fatty. This case is exactly the same. It's not to the same extent. This is exactly the limit between the two buds. Physiologically, some people have tried to see if there were differences between the two buds. So this slide is a little bit busy, but basically these authors have decided to explore the concentration of insulin, of glucagon, and the polypeptide P. Maybe not everybody knows what it is, I will tell you. This is of some interest for some of us. And the concentration of these polypeptides are very different within the head, within the tail. I made something which is more graphical for you to understand that. If you go to the tail of the pancreas, you get some high level of insulin and the glucagon as compared with the head, where the insulin is just half, the glucagon is absolutely absent, while the polypeptide P is 120 as compared to 18. So these places are completely different physiologically. Glucagon as insulin, as you know, they stimulate the intake of food. Who is asking for food? The vessels, the brain. Remember that the posterior part of the pancreas was built by the vessels and by the notochord. What is the role of the polypeptide P? It moderates hunger. So if you take it, no hunger anymore. And what is it? This is related to the liver and the bile ducts. And the liver says, wow, oh, too much, that's it, stop it now. Okay? So the dorsal part of the pancreas is asking for food. The ventral part is saying, that's all, that's enough. And these are two quite different glands. Don't take it to have a regimen, please. So there is some kind of mystery of the insonate process, which is the part of the ventral bed. And we can now explore it with something. Everybody knows what it is. We call that the gallium dotatok. And this is a tracer that we use now with PET-CT in order to detect some neuroendocrine tumors. Dotatok. And our surprise was to see that in the initial images of the dotatok, this patient is normal. This patient is normal. Look like the uptake, the enhancement of the insonate of the ventral bed of the pancreas, even with a very high SUV. This is different from a tumor, which is round shape. This is oval shape. This is physiological. So there is a huge difference, physiological difference between the two beds of the pancreas. Because we are on the tracer, on the left side you can see the FDG PET-CT, no enhancement of the pancreas. And the other tracer that we use for detection of neuroendocrine tumor, and this tracer, which is the F-DOPA, is an uptake in the pancreas, mainly in the body, in the tail of the pancreas, not much in the head of the pancreas. So as you can imagine, this is quite interesting from the physiological point of view. The second point, the second consequence, that the rotation of the ventral bed is a long trip, a very long trip, and this explains the frequency of some abnormalities like the annular pancreas. And third, there is sometimes a confusion between the annular pancreas and the ectopic pancreas. The chest X-ray I showed you was an ectopic pancreas. This is a result of an error in the induction of the bed. It's another ectopic bed and not an abnormality of the rotation of the bed. This is quite different. So the main clinical abnormality that we are is ectopic pancreas and annular pancreas. We will see some unclassified abnormalities, and we will see also the duct fusion problems. What is an ectopic pancreas? This is pancreatic tissue that has no connection, vascular or glandular communication with the main body of the pancreatic gland. The locations are mainly stomach, duodenum, small bowel, metal diverticulum, and there are some case reports in all these organs, like mediastinum I showed you as an introduction, and even in the fallopian tube, as you can see. Clinically, most of them are asymptomatic, but sometimes it's revealed as a pancreatic disease because it's pancreas, so it can be diseased as the rest of the pancreas. Sometimes there is hemorrhage, sometimes there is pain, and when it becomes symptomatic, it's an acquired symptomatology between 40 and 60. So how does it appear? It appears as a mass, which is related to the bowel. Here is the duodenum wall. In endoscopy is something like a smooth margin, a smooth tumor, some mucosal tumor, and histologically this is pancreas with some kind of pancreatic duct. Endoscopic ultrasound is very interesting, and especially because it shows sometimes some kind of a duct within the ectopic pancreas, which we usually cannot see on CT. On CT the images are quite challenging. Sometimes it's endoluminal, sometimes it's extraluminal. It's usually very different from one case to another one. There is enhancement after iodine. It's similarly more or less to the pancreatic gland, but it has been developed some criteria in order to differentiate an ectopic pancreas from the GIST tumor. First of all, the localization doesn't help that much. Second, the ratio of width versus height of the tumor, which is more than 1.4, it's in favor of an ectopic pancreas as compared with the GIST. The mucosal enhancement is in favor of the ectopic pancreas, first border as well, and endoluminal development. And what was said in this paper is that 2 criteria out of these 5 are present. This means that this is an ectopic pancreas, and CT is quite challenging. The annular pancreas is completely different. In order to explain it, we have 2 theories. One is from Leco. Leco theory is like that. We have a rotation of the dorsal bud, no problem. But the ventral bud does not move completely. It's just like in the group, some are walking, some are staying, and at the end of it, we have something like a spread over, because some have been to the place they want to come, and some have stayed there because they just feel okay there. So it's something like an annular pancreas, but not complete. And this is the reason why there is another theory, which is the Leco theory, which is Baldwin theory. And this Baldwin theory says that, okay, in order to explain it, we need two buds. And what happens with the two buds? They're both going both sides. And at the end of it, if they are going both sides, we have gland all over the duodenum. And we have one duct back, and we have one duct in the front. We may have one duct in the front, and this could be complete or incomplete. And this theory explains why we have complete circles around the duodenum. This is what we see surgically. Around this is the duodenum, this is the annular band of the pancreas. And I should say that if you ignore it, you just don't see it on computer tomography. I bet that everybody would say that the pancreas is normal, and probably nobody would see the annular pancreas. Look at this case. I show you the duodenum, and now the pancreas. Here it is, here it is, here it is. Because the annular pancreas is not a non-horizontal on an axial plane, but it's oblique. So you probably don't have the ring on a single slice. And you have to build it mentally. So if you look at that again, without the drawings, this is the anterior part, this is the posterior part, and this is the external part of a complete annular pancreas. Might be easier in MR because of the contrast between the duodenum and the pancreas. And this is the same case. Look at the pancreas back. This is a complete ring. This is part of the ring only. This is another case of annular pancreas. Not so easy to find out. But if you go to the MR pancreatography, you can see the normal bile duct, you can see the normal Wilson duct, but you can also see this tiny little canal which is going around the duodenum. Okay? So annular pancreas is not so easy, and there are some minor equivalents. And there is a sign that you sometimes will look, which we call the lobster claw. What is the lobster claw? This is a pancreatic examination that was considered as completely normal. But one side was a little bit different. Look at the duodenum, look at the pancreas, and look at the anterior part, look at the posterior part. And this is exactly what we call the lobster claw. This is the sign. And you can see it in many cases, in most cases, because the external part of the annular pancreas is only a fibrous band. And when the patient has symptoms, the fibrous band may be also an obstruction. So now you will see the lobster claw in every single examination. But some cases are unclassified. I would like to show you this patient. Obviously, the patient has pancreatic disease. Look at the body and the tail, it's small. There's some mild dilatation, irregular dilatation of the Wilson duct. If we go a little bit further, we can see the explanation of this. And this is a tumor, this is a pancreatic adenocarcinoma. And if you go down again, you find again the head of the pancreas, which is normal downstream of the tumor. But there is something which is a little bit unusual. Look at this place here. This is a little bit different from this place. And if you go a little bit down again, you can see that there is a duodenum, there is one part of the pancreas, and there is another part of the pancreas here, maybe with a duct. Maybe it's more clear with the MR, This is the versum duct dilatation in the same patient. This is a tumor. This is the pancreatography. You can see that there is a tumor and bone duct. And this is the other bud with a very small canal in it. This is magnification. Once again, tumor, versum duct downstream of the tumor, duodenum, and another pancreatic duct with a separation with the main gland and some kind of versum duct in it. Okay? 3 different parts. So this is another case, normal pancreas. However, look at this deep fissure of the gastroduodenal artery between the main body of the pancreas and the other bud, which is completely different. This is down again, look at the fissure, look at the second bud, and look at the main gland of the pancreas. And this is quite common. As soon as you start to look at it, you find it. Another special abnormality can be interesting from a surgical point of view. This is probably frequently overlooked. The first time I saw that in the literature, I thought that it was another fancy case from a Korean surgeon, as usual. And he said that, well, this is normal. This is seen from behind. This is a portal vein, this is a plenic vein, this is a mesenteric vein, this is a common bile duct, arteries. And sometimes there is some pancreas behind the portal plane, which shouldn't be. This is a form with the portal pancreas behind the portal vein. This is case of pancreas behind the mesenteric vein, and this is case of pancreas all over the world. And in his article, he showed that this is pancreatic, this is a portal vein, this is a portal vein and a splenic vein, and this is a portal vein with pancreas all around. And as you can imagine, when you go for pancreatic surgery, it might be a real problem. He said that it's very frequent, it's more common in women. It says that there are consequences for surgery, but I did not believe it, obviously. You should never believe the literature, obviously. The same day, I made the second read of the cases. I found 3, the same day. This is one of them, the same day. This is the portal vein, this is the pancreas all around. And this is very common. If the patient is okay, there is no disease of pancreas, no problem. If there is a tumor, if there is a cyst, if there is a question of surgery, it might be a problem. Finally, I would like to go very briefly to duct fusion failure. The fusion of the 2 buds occurred in the 7th week of the embryo, in the life of the embryo. And it affects 5 to 10% of all patients. Now, there are many, many different appearances of what we call the pancreas division, complete, incomplete, everything. But by the way, why is there a fusion, and why is the minor papilla and the major papilla not on the right side of the gland? Because the big pancreas, which is the dorsal pancreas, have a small hole, and the ventral pancreas, which is a small pancreas, has a big hole. Why? And at the end of it, all the stream of the fluid of the pancreas is supposed to go to the smaller pancreas. Why? The smaller is eating the big? No. This should not happen usually. What happens? It happens because there is biflow. And the biflow is a huge flow. So it models the papilla, the major papilla, in order to be bigger. And this is why the small pancreatic gland has the benefit of a big hole. And it calls the rest of the pancreas, join me, it's easier to get out of the pancreas this way. And this is probably why there is a fusion of the ducts of the dorsal bud and the ventral bud. So what happens finally? Finally, we have an opposition of what we call the divisum, which is the separation of the duct from the the body and the tail that goes to the minor papilla with no communication, and normal cases where there is a complete fusion or a partial fusion with both papilla being patterned. It's quite easy. It's quite easy to look at it. This is a case with this patient. You can see the Wirsunduk. The Wirsunduk is going down, down, and suddenly just crosses the bile duct. This is the common bile duct. This is the Wirsunduk, which is not the Wirsunduk, which is the Santorini duct. There is no reason for it to cross the bile duct. The bile duct is vertical, the Santorini is horizontal. So at some place they cross. If they cross, it is a pancreas divisor. And when we go down, once again, we have the Santorini duct that goes to the duodenum, while the bile duct is getting down and down again. In order to see if it is a normal case with two ducts or if it is a complete division, it's very simple. Just take this slice, where you can see the Wirsunduk and the Santorini duct. If there is nothing accompanying the bile duct, it is a complete pancreatic division. If there is a Santorini duct, but there are twin ducts, this is a normal case with two ducts. It's even easier with the magnetic resonance cholangiography, seeing the crossing of the two ducts. And if you have some time to lose, you can do it as well on CT with a minimum intensity, showing the crosses of the two ducts. This is a normal case. Is it a clinical problem? Not for 95% of the individuals, because they have no symptoms and we will have no symptoms. Yes, for 5% of these, that will have more or less severe symptoms of pancreatitis, because the minor papilla is not modeled to have the whole stream of the pancreas, and in some situations it may become a problem, not so easy to treat. What is interesting is that 20% of the patients who have developed pancreatitis associated with pancreas division have also some kind of genetical abnormality. So the pancreas division is not the explanation in itself, but the pancreas division is another problem associated with other problems to make this patient having pancreatitis. So I would like to conclude now. I think it's, these images are very frequent. They are commonly overlooked. And most are explained by the embryology. I hope that you enjoyed a little bit this trip to embryology. There are some potential clinical consequences, and today there are some kind of evolving treatment strategies, especially in the case of the pancreatic divisor. I thank you very much for your attention.